Hi everyone, this is Tim, your Block 3 lecture instructor, and today's voiceover PowerPoint is going to be on the gallbladder, liver, and pancreas. It's fairly short and sweet and to the point. I think it's about a half hour long. I try to make it as light as possible, so if you have any questions or concerns or a little bit lost, let me know. So the first slide here is actually the anatomy of the liver, gallbladder, biliary system, and the pancreas. I really put this on here just to kind of familiarize yourself with where things kind of lie, just so you have an idea. The first thing we're going to talk about is the gallbladder, cholelithiasis. It's an inflammation of the gallbladder. I put on here 40 fat and fertile. Not to be derogatory or insensitive, but when I was in nursing school, we learned that people, or specifically women, who actually have their gallbladder removed tend to fit in a category which is over the age of 40, tend to be overweight, and still within the age range of being fertile and having children. So again, I put this on here because I think once you start to practice and start to take care of patients who have certain diseases, you tend to either put them in categories or stereotype them, or however you want to call it, and it allows you to kind of plan the day a little bit better. So again, when you start taking care of these patients, you'll find that they do fit within that 40 fat and fertile range, and you'll remember me. So anyways, there's two different types of gallbladders or cholelithiasis, which is acute or chronic. With acute, its inflammation is caused by the stones, and with chronic, it's an inefficient bile emptying and contraction by the gallbladder itself. So with acute, it's stones. You've got a lot of them. And they're trying to be passed, and it does cause the pain and the inflammation. With chronic, it's because of the fact that the actual gallbladder itself is not able to excrete the bile, and that's what's actually causing the pain. With cholelithiasis, gallstones are hardened deposits of digestive fluid. Gallstones could vary in size and number and may or may not cause symptoms. I've had some patients that have had a few stones and they act like they're dying and the world is coming to an end. I've had some patients who have so many stones that the gallbladder needs to be removed and they act as if it was nothing. So it just depends on the person and how they actually are able to adjust to the actual pain and the actual problem. People who experience symptoms usually require gallbladder removal surgery. Gallstones that don't cause symptoms usually don't need to be treated. I will tell you that patients who have very little stones, who have enough pain to come to the hospital, that seem to have pain management within about 24 to 48 hours, will usually go home, follow up with their primary care physician, and then make some sort of appointment to go to a surgical center where they can actually remove it first thing in the morning. By mid-afternoon, they're having something light to eat, and by afternoon, they're actually going home. There's other patients who are completely full of stones that are having a lot of problems, a lot of inflammation, high white blood cell count. They need to emergently have it taken out, and they take it out as soon as they possibly can. So there's your two different types of gallbladder patients that need surgery. As far as assessment wise, you're definitely going to see the nausea and vomiting. You're going to see indigestion, belching, and flatulence. I put in here in red epigastric pain that radiates to the scapula 2 to 4 hours after eating fatty foods, and may persist for 4 to 6 hours. So basically what this means is that typically a patient will eat, and within 2 to 4 hours, the epigastric pain comes back. It radiates to their scapula. They're starting to have nausea and vomiting. They're having all the symptoms come back, and it could last up to 4 to 6 hours. Basically, the bile is there to actually break down fat. And if you have a large meal or if you have something with a lot of fat in it, then it starts to act up. And this is how it's actually showing you and presenting to you that it is a gallbladder problem. And it's because of the pain and where it is and how long it lasts. Pain is usually localized in the upper right quadrant. Your patient's going to have some guarding. You're definitely going to have a mass palpate in the right upper quadrant, which is the inflammation of the gallbladder. That's actually called the Murphy sign, and I posted a link to the YouTube video where they actually show you how to do that. It's actually pretty interesting, and I've always seen doctors do it, so it's pretty easy to learn. You're also going to have an increased temperature. You're also going to have dehydration because of the nausea and vomiting. Your patient's not going to want to eat or drink anything. And they're also going to have an increase in their amylase and lipase labs. Interventions, you're definitely going to make your patient NPO because as soon as they eat, the pain's going to come back. You also want them NPO in case, a doctor shows up and says, hey, you know what, I think it's just inflammation enough for us to remove it, and as long as they're NPO, they can do it as soon as they need to. You definitely want to control the nausea and vomiting. You can give either Compazine, Zofran, or Phenergan. Compazine is probably going to be your first line of nausea and vomiting medication because it's pretty mild. It actually works. If it doesn't, Zofran is a pretty common one to use also, and then Phenergan's pretty much like the best to use, but it also has a sedative effect in it, and you don't always want to just knock your patient out. For pain meds, you can definitely do a little bit of morphine in order to cut down on the pain. And if you have patients who have chronic pain issues, Dilaudid seems to work a little bit better. Anticholinergics is going to be oxybutynin or ditropan. It's a relaxant, or it prevents contractilities, and that's a lot of times this is what causing the gallbladder pain, is because the gallbladder is trying to contract to push out the bile, and that's what causes the pain. Diagnostics and surgery. So I put on here, what labs are you going to be looking at? Kind of think about that because, again, your patient is going to present to you without having surgery yet. They've already pulled the labs from the emergency room, and now you're looking at stuff going, I wonder where the problem is. If labs are high in, AST, ALT, it could be one organ. If it's high in the amylase and lipase, it could be something else. White blood cell counts, a lot of different labs will tell you exactly, or at least point you in the right direction as far as what's causing the problem, and be familiar with those. They're definitely going to do an ERCP, which is an endoscopic retrograde cholangiopancreography. And this is basically going down your throat into your stomach, into the actual area where the gallbladder is, and they're really looking to see if stones or anything that's actually obstructing the common bile duct, because a lot of times they can go in there. If they can remove it, they don't have to remove the gallbladder. Again, the gallbladder actually breaks down the fat, and every time you eat, it's trying to break it down. And if you remove it, you can still live, everything will still work, but you still want something to always be part of you. So surgical removal, again, it's going to be laparoscopic. They're going to do 3 puncture sites. They're going to go in, they're going to cut it up into pieces and suck it out. They're going to put steri strips over top of those puncture sites. Again, discharge teaching for your patient, you're going to make sure that they're not going home and they're not laying by a pool. They're not going to get into bath water. You don't want to do freestanding water, because what will happen is that those 3 puncture sites will fill up, and that's an entryway of bacteria into your peritoneal cavity. So definitely make sure that you tell them that, because we live in Arizona and everybody and their brother sits by a pool, and next thing you know, it's too hot. They get in, next thing you know, they've filled up with pool water. All right, so moving on to hepatitis, cirrhosis, and liver failure. So hepatitis is the inflammation of the liver caused by a virus, bacteria, or exposure to hepatotoxins. There are 5 different types of hepatitis. There's actually more, but these are the most common that I had chose to kind of point out. There's hepatitis A, which is usually fecal to oral. Usually can be picked up from fruits and vegetables, and usually it's transmitted between kids. They tend to not be able to keep their fingers out of their orifices, and next thing you know, they're touching stuff and putting things in their mouth. So it's a very easy way for them to actually get it. With hepatitis B, it's actually transmitted by blood and bodily fluids, and can be actually transmitted to anyone. The positive thing about the medical field is we're all have been inoculated for hepatitis B, so we're less likely to get it, or we're very low risk, but not everybody has been treated. There's also hepatitis C, which is also blood and bodily fluids, and that can be transmitted to anybody. For D, it's actually by blood products, and usually it's only transmitted between people who have hepatitis B. And for hepatitis E, it's usually caused by water-borne, and it's usually transmitted to travelers. There are 3 stages of hepatitis. There's the pre-icteric, there's the icteric, and there's the post-icteric. With preicteric, your assessment is going to be more flu-like symptoms, anorexia, nausea, vomiting, and diarrhea. Your patients are going to have pain, which is going to be more specifically to the head, muscle aches, and polyarthritis. And for preicteric, your serum, bilirubin, and enzyme levels are going to be also elevated. With icteric, you're going to have an assessment of jaundice, pruritus, dark or tea-colored urine, clay-colored stools, and a decrease in preicteric phase symptoms. So you're going to go from preicteric and having the feeling like you have the flu, nausea, vomiting, diarrhea, the headache. All those symptoms when you get to the icteric are actually going to be decreased and probably eventually go away. I think the biggest thing that you can take from the fact that patients with hepatitis are going to be that dark or tea-colored urine, the clay-colored stools, and the jaundice. With posticteric, you're going to see an increase in energy levels, subsiding of pain, minimal or absent of gastrointestinal symptoms, and the serum bilirubin and enzyme levels will return to normal. So at this point, everything kind of has gone away as far as the symptoms, and it seems like you're feeling much better. So for lab assessments of hepatitis, you're going to do the alanine aminotransferase levels. Normal is 4 to 36. You're also looking at the aspartate aminotransferase levels, which is 8 to 33. Alkaline phosphatase levels, which normal is 4.5 to 13. And the total bilirubin levels, it's going to be elevated in the serum and in the urine, and normal is lower than 1.5 milligrams per deciliter. I don't think that anything these are good to know. I wouldn't necessarily memorize them to a T specifically. Maybe the total bilirubin level, and that's probably because more of the liver and because of the actual gallbladder. So as far as cirrhosis, a chronic progressive disease of the liver is diffused generation and destruction of hepatocytes. Scar tissue caused by replaced destruction of hepatic cells. So again, the cirrhosis is more of the destruction of the liver itself, but it can actually regenerate and help fix itself, but it also causes scar tissue. And because of that, that's when the hepatic cells are being more damaged, and the liver seems to be less viable or working as well. But it is a progressive disease, and it's also very chronic. Complications, you can have portal hypertension, which is an increased pressure in the portal vein. You can have ascites, accumulation of fluid in the peritoneal cavity, venous congestion of the hepatic capillaries. Ascites for me is more of that alcoholic who has drank themselves to the point where they have received, they're beyond the hepatitis and they're actually into the cirrhosis of the liver. They've done so much damage because of the portal hypertension, because the blood pressure tends to be, we call it backed up, but because it's so high, it's causing the ascites, which is pretty much a distension of almost every small vein, artery, and capillary in the abdominal area, and because of that, things tend to break and bleed and even leak at times as far as in the vascular system. And that's what ascites is. Esophageal varices, it's the same thing as ascites, but it's more of the distended esophageal veins in obviously the esophagus, but they tend to rupture. And that's where you get the upper GI bleeding in the patients who come in with a nausea and vomiting and that, bright red frank blood. And again, it's more blood pressure related than anything else. We have coagulation defects. Bile fats prevent the absorption of vitamin K. Again, your liver is what's going to control the clotting factors of your blood. With jaundice, you're unable to metabolize bilirubin and excrete it, and that will actually build up and circulate in the system, which causes your skin to become yellow. I've actually seen patients that were so bad that they practically glowed in the dark. That's how yellow they were. Also, other complications of cirrhosis is going to be encephalopathy. You tend to have a very large buildup of ammonia in their body, and that ammonia level will actually cause altered level of consciousness. And the only way that one of the best ways that we do this in the hospital to make it lower is to give your patients lactulose. Lactulose is, I've been told, I think it tastes nasty, but by patients who have taken it, think it tastes like maple syrup. It's very thick, but one of the side effects of lactulose is diarrhea, and that's the whole point. What it does is the lactulose actually binds to the ammonia, and it gets rid of it by having diarrhea. And I've actually seen people first thing in the morning being completely disoriented and not with it, and they'll take the lactulose, they'll have the diarrhea throughout the day, and by evening time they're actually kind of with it. So it's a pretty good drug, but unfortunately it causes severe diarrhea. And for a patient who is not alert and oriented, and having to go to the bathroom every 15, 20 minutes to a half hour to an hour, it causes a lot of problems. So let's see here. Other complications is the hepatorenal syndrome. This is renal failure due to liver failure. So again, you're having the liver failure. It's actually affecting that, but then it also starts to affect other organs, specifically your kidneys. All right, so for assessment-wise for cirrhosis, I have a handout that I'll be giving to you. There is a lot to assess, but I think once you physically actually see it, it makes a little bit more sense. Interventions: elevate the head of the bed to minimize shortness of breath. Diet high protein with lots of vitamins because they're really not absorbing anything. Supplements are going to be vitamin A, C, K, folic acid, and thiamine. You're going to definitely restrict the amount of sodium in the fluids that they consume because water follows salt and vice versa. So if you have patients who have cirrhosis and are salting their foods or taking a lot of foods that have a lot of salt in them, they will actually start to become very distended and actually start to hold on to that water. You can also do internal feedings or TPN. This is really just to give that liver and that gallbladder pancreas area a little bit of time to just kind of relax a little bit, and kind of the TPN will actually give them the nourishment that they need. So you also could give diuretics. The diuretics will work in the opposite way that the actual restriction of sodium and fluids is. So the diuretics is really going to pull all the fluid off, and with that will actually come the salt. So it helps kind of a lot with the distension and putting less on the vascular system. So it definitely will help with the esophageal varices. It'll help with the ascites. It's just like I said, it's getting their blood pressure back down and helping a lot of other symptoms. With that, you also want to do definitely strict eyes and nose. You want to make sure what goes in is coming out. If your patients are being weighed daily and you start to see that their weight is starting to increase, most likely it's fluid going somewhere or they're at least holding on to it. So you want to be able to make sure that you kind of know eyes and nose to make sure what goes in is coming out, and also daily weights to make sure that they're not retaining all that fluid. See other interventions. We talked about the weight daily and measuring abdominal girth for distension. You monitor their level of consciousness. Monitor for tremors. Because remember, if they're going to get diuretics to pull off some of the fluid, a lot of times they'll lose the electrolytes. There are several electrolytes that will cause the tremors, so definitely make sure you know which ones those are. Other interventions, I think fruity, musty breath is probably more of an assessment than anything else. Monitor coagulation labs. You're looking at PT-INR. You're looking at PTT. You're making sure that, again, an organ that is to control the clotting factor is not working appropriately. So if for whatever reason they have to go to surgery, or you're finding out that their blood is becoming way too thin, you're going to start looking at other things to make sure that they don't lead to death. Administer antibiotics for prevention of bacterial diseases. Avoid opioids. Abstinence of alcohol. And again, I'm not trying to be derogatory, but I also think that based on stereotypically, most patients who have gone through this process of hepatitis and cirrhosis and liver failure, a lot of times it is more alcohol related. So if you're trying to do all these steps to be able to help fix them, you need to give them the resources as far as to be able to stop drinking, and if not, then it's just causing more to the problems. And I've actually taken care of these people. I've taken care of patients who have come to us with cirrhosis, and they're very distended, and they're coming in with GI bleeds, or they're coming in with esophageal varices. I'm giving them diuretics. I'm doing all these things to be able to pull off the fluid. I'm giving them lactulose to be able to bring their ammonia level down. I'm doing all these things and I'm fixing them, but then they go home and then they drink until it gets bad again, and then they come back. And I've taken care of those patients where I've seen them and I've helped them. I took care of them. I got them better. And then within about a month or so later, they're back and I'm taking care of them again. And they'll even tell you, oh, I'm back, and this is the problem, things like that and stuff. So a lot of times it really is as simple as trying to give them the resources for them to stop the drinking. Now, whether they can or can't, I mean, that's, it's I know it's hard, but we got to be able to do something, or we're just really continuing the cycle. We also want to do instructions on paracentesis to remove abdominal fluid. Paracentesis is basically there's a lot of fluid in the abdominal area, and the paracentesis is putting in a needle and aspirating as much fluid as they possibly can from the abdominal cavity. So albumin. Albumin is a protein made by the liver. It makes up about 60% of the total protein in the blood, and it plays many roles. Albumin keeps fluid from leaking out of blood vessels, nourishes tissues, and transports hormones. It also transports vitamins, drugs, and substances like calcium throughout the body. Levels of albumin may decrease to a greater or lesser degree when conditions interfere with its production by the liver. Increased protein breakdown and increased protein loss via the kidneys and expended plasma volume, which is diluting the blood. So essentially, albumin is made in order to transport a lot of stuff. But for the most part, I think what I really want you to get out of this is that albumin keeps fluid from leaking out of the blood vessels. It actually causes third spacing. So when you have those patients who have gone from abdominal girth and the varices to now being pretty much pitting edema and swollen everywhere, and especially with already having liver problems and blood pressure issues. The blood pressure issues is because the fluid is leaking, is going to that third space, and there's not enough vascular volume, and that's what drops our blood pressure. Well, the albumin can be given to pull the fluid back into the vascular system and allow the blood pressure to go back up. So let's see here. Two important causes of low blood albumin include severe liver disease. Since albumin is produced by the liver, its levels can decrease with loss of liver function. However, this typically occurs when the liver has been severely affected. There's also kidney disease. One of the many functions of the kidneys is to conserve plasma proteins such as albumin so that they are not released along with later products. So your liver actually produces the albumin to keep things, keep the fluid into the vascular system and also to transport things. But the kidney's role is to make sure that they don't actually lose it by excreting it. So if you're having kidney disease and also liver disease, not only is the albumin low, but whatever you did have is now being excreted. So you want to make sure that the liver and the kidneys are also functioning as best as they possibly can. Other labs, you're going to look at serum bilirubin, which is 0.1 to 0.4 milligrams, which is very important, so memorize it. You're looking at albumin levels, which is 3.5 to 5.5 grams per deciliter, which is also important, so memorize it. You should know by now PTT and INR, so know those. You're looking at AST and ALT and your ammonia levels. So these labs are something that you definitely need to know, whether it be for the test or whether it actually be for your normal everyday practice. So start memorizing them. All right, so on to pancreatitis. Inflammation of the pancreas with associated escape of pancreatic enzymes into surrounding tissues. You can have an acute pancreatitis, occurs suddenly as one attack, or can be recurrent with resolution. So you either can have a pancreatic attack, which is basically nausea, vomiting, and a lot of pain, and it can actually be resolved on its own and go away, or it can actually come back, but within a couple days after some interventions, actually can go away again. Or you can have chronic, which is continual inflammation and destruction of the pancreas itself with scar tissue replacing pancreatic tissue. So with chronic, it's you get better, and with being better causes scar tissue, and then you get worse again and you have another attack, and then it actually causes more scar tissue. So essentially the chronic is a recurrence of pancreatitis with the fact that it's breaking down the pancreas as it goes. Acute pancreatitis assessment, you've got abdominal pain, which is mid-epigastric. You've got left upper quadrant and radiating to the back. Pain aggravated by fatty meals, alcohol, and laying in a recumbent position. Abdominal tenderness and guarding, nausea and vomiting, weight loss, and absence of decreased bowel sounds. Acute pancreatitis diagnostics. So basically you're looking at labs, which is going to be an increased white blood cell count, increased glucose, increased bilirubin, increased alkaline phosphate, increased urinary amylase levels, increased serum lipase, and increased serum amylase. So for amylase and lipase, both are key digestive enzymes. Amylase breaks down starch. A normal level is 23 to 85 units per liter. And with lipase, it actually breaks down fat. And a normal level is 0 to 160 units per liter. Now, pancreatitis is anything over 200 units per liter for both enzymes. And that's very important. Acute pancreatitis interventions, you're going to make sure your patient is NPO because eating is going to exacerbate the pain. You're also going to give them IV fluids for hydration. You can also do TPN if there is severe nutrition depletion. So if you have a patient who has pancreatitis who has been there for at least a week or two, TPN might be the way to go to at least give them the electrolytes and the minerals and the vitamins they need to get the nourishment. You're going to administer vitamins and minerals if they're needed, and a G-tube, which will decrease GI distension and suppress pancreatic secretion. Demerol for pain. I put this in here because for whatever reason, according to my guidelines and what I had to teach you, Demerol was one of the meds. Unfortunately, we don't do Demerol on a med-surg floor anymore. In fact, I don't think we've done it for the last 10 or 15 years. But I put that on there. Again, this is not used anymore because of the side effects, but we tend to usually do morphine and Dilaudid. You can do antacids to neutralize gastric secretions. You're going to administer anticholinergics to decrease gastric motility and inhibit pancreatic enzyme secretion. So you have to remember, with pancreatitis, this is actually an increase of enzymes and it's an increase of excretion of enzymes, but that's what's actually causing the pain, and they're actually excreted because of the gastric motility. So if you can slow down the gastric motility and even decrease the GI, what am I trying to say? If you could decrease your gastric juices or the acids produced in your stomach itself, it slows down the excretion of the enzymes from the pancreas. So they kind of work together. If one goes up, so does the other one. So if you can keep them both down, you tend to kind of slow down the pancreas itself, and that actually will decrease a lot of the pain too. Other interventions is going to stop drinking alcohol, follow up with doctor appointments. A lot of times patients will get better, they'll leave, they really won't follow up with anybody, and then within about a month or so, everything is back to being exacerbated and they come back to the hospital. Patient must call the doctor if they're having acute abdominal pain, if they're having jaundice, clay-colored stools, or dark-colored urine. At this point, they're actually it went from pancreatitis to now affecting their liver. It's possible that they actually have started a pancreatic cancer, and it's actually metastasized to their liver. Chronic pancreatitis assessment, you're going to have abdominal pain and tenderness, left upper quadrant mass, steatorrhea, and foul-smelling stools that may increase in volume as pancreatic insufficiency increases. You're also going to have some weight loss, jaundice, and symptoms of diabetes mellitus. Again, the pancreas is where the insulin is made and released, and if you are actually having problems with it and it's not functioning the way it should, then you'll actually start to become diabetic. Interventions, you're going to look at dietary, you're going to limit the fat and the protein, avoid heavy meals, you're going to limit or decrease or stop drinking altogether. Vitamins and minerals, which will increase caloric intake, administer pancreatic enzymes. You can actually take amylase and lipase, which is pretty good. Administer insulin to control the diabetes mellitus, teach about glucose management. So you have a patient who is, let's say, either a non-alcoholic or an alcoholic, 40 some odd years old, they're having cirrhosis or they're having problems with their pancreas to where it's not functioning correctly. They've never been introduced to diabetes before, and all of a sudden now you're telling them they're diabetic. You're having to start from scratch. How to prick their finger, when they should actually test their blood sugars, giving insulin and how do they dose it, and diet and exercise. I mean, there's just a lot of information for somebody who has never been diagnosed with being a diabetic before, and you're starting from scratch. And you're also telling them they're having pancreatitis and they're going to have other issues. Notify a physician if there is an increase of steatorrhea, abdominal distension, cramping, or skin breakdown. Well, that wasn't too bad. 30 minutes. All right, so let me know if you have any questions. I think that if you got anything out of this PowerPoint voiceover, I think that it's between the gallbladder and the pancreas and the liver. These are either chronic issues, which is most likely, or they're acute problems that will turn into chronic issues, and a lot of it's more of interventions and really treating symptoms. So it's a matter of trying to retrain your patient how to think, what works, what doesn't work, what will prevent pain and suffering, and try to make them better. So if you have any questions, let me know.